Good evening. My name is Kathy Harley, and as the CEO of Nurses Specialized in Wound, Ostomy, and Continence Canada, we would like to welcome you to this NSWOC Continuing Education webinar. I live and work on the unceded territory of the Algonquin and Anishinaabe people. And this evening, we have some special guests who will be presenting on saving limbs and lives, an Ontario Lower Limb Preservation Integrated Care Program. Our distinguished speakers this evening, I will introduce them to you, and then we will go into the presentation, the formal part of the presentation. And also, as they're presenting, we would encourage you to put your questions in the Q&A box at the bottom of the Zoom screen. If you could refrain from putting the questions in the chat and keep them in the Q&A box, we'll have a moderated Q&A session at the end. And so we have three distinguished guests this evening. Our first speaker is Dr. Christine Murphy. Christine is the past president of NSWOC. She's a registered nurse and a Canadian Nurses Association certified NSWOC. She studied tissue viability with professional practice at the undergraduate level and graduated from the Masters of Clinical Science of Wound Healing from Western. And then she went on to do a PhD, and her doctoral research investigated the assessment and treatment of lower extremity wounds in the vascular surgery population with a focus on ultrasound, debridement, and wound infection. She has been involved in numerous committees. She's been involved with the Canadian Society of Vascular Nurses. She was involved as a panel member on the 2013 RNAO Best Practice Guideline Update, Diabetic Foot Ulcers, and has also been involved in the RNAO Best Practice Guideline for pressure injuries. She currently works at the Ottawa hospitals in complex surgical and vascular surgery wounds. And she is originally from Gloucester, England, and makes her home in Ottawa. Our second speaker is Lynn Scholey, and she's a registered kinesiologist with 25 years of experience in cardiac rehabilitation. She's been with the Ontario Health for 6 years, working on the clinical team supporting the vascular portfolio, which includes planning and strategy work related to aortic aneurysms, carotid artery stenosis, and lower extremity occlusive disease. Her biggest project is the Lower Limb Preservation Integrated Care Program, and as a member of the clinical team and Indigenous Health team, she's supporting demonstration programs around the province with implementation of change initiatives to prevent lower limb amputations. And our third speaker is Dr. Lyndsay Orr. Lyndsay has been a registered physiotherapist for 24 years with experience in multiple clinical settings across various sectors of healthcare. She has a clinical passion for wound care and completed her Master's of Clinical Science in Wound Healing in 2008 and her PhD in 2018. She's an assistant professor at Western University for the Masters of Clinical Science of Wound Healing program and is a lead at the Ontario Health for the value-based care team. In this role, Lyndsay works closely with the Ontario Health teams on the implementation of integrated pathways, including the Lower Limb Preservation Project. I would now like to turn things over to Lynn, and she will do a land acknowledgement to start with.
So good evening. Lots of familiar faces I see in the chat there. I would like to begin our webinar this evening by sharing a personal land acknowledgement. So I am speaking to you today from the city of Toronto, where I was born and have lived most of my life, except those university years out of the Toronto area. And although I didn't grow up with this recognition, I now recognize and acknowledge this land as the traditional territory of many nations, including the Wendat, the Anishinaabe, the Haudenosaunee, and the Mississaugas of the Credit. And while I live in Toronto, as I mentioned, I spend part of my summers at my family's cottage on an island on Georgian Bay, land that has been in my family this year for 100 years, but is Anishinaabe First Nations territory. And despite the monument on a nearby island celebrating Samuel de Champlain's arrival in the area by canoe in 1615, I now recognize and acknowledge that it was actually Indigenous peoples who were the original caretakers of the land for thousands of years prior to the arrival of Samuel de Champlain and the European settler community. So as you will hear tonight, Indigenous peoples in Ontario experience amputation rates up to 7 times the provincial average. So my commitment to reconciliation is to create, strengthen, and sustain relationships with First Nations, Inuit, Métis, and urban Indigenous peoples in Ontario. I will work to co-design Indigenous approaches to care and culturally safe care delivery to reduce the number of preventable lower limb amputations experienced by Indigenous peoples. And I also commit to continuing to learn about the history of Indigenous peoples in Canada and to work towards a better understanding of what reconciliation means and looks like in action every day. Thank you. So Lyndsay, if you can just forward the slides, I'm happy to share our objectives for tonight's talk. So Chris will begin the presentation, introducing our Ontario framework for lower limb preservation. Lyndsay will then provide an overview of the Ontario Lower Limb Preservation Program, including our work with the demonstration programs. And then I will finish up with some information on the Indigenous-focused work that we're doing with the demonstration programs around the province. So Chris, over to you.
Well, thank you, Lynn, and thank you everyone for joining us this evening. We all have busy lives and so many things to do, so it's really impressive that you've given your time up for this. I may look a little strange. I'm not sure how I'm appearing on video. I'm actually in a high school hallway. I have this NSWOCs, we tend to have interesting side hobbies. I'm in a amateur rehearsal orchestra, and on Tuesdays and Wednesdays, 2 different orchestras. And tonight I'm at Brookfield High School, and you may hear some of the practicing of the first half of the session in the background. So hopefully they're quiet. I've tried to move away from them as much as possible. Anyway, what are we here to talk about tonight? Well, another passion of mine, of course, is lower limb amputation prevention. As many of you that know me know, this has been my passion for many, many years, working with the Vascular team, and originally as a young nurse seeing people with these amputations and life-changing situations, as we know. More recently, this has become a focus for the ministry. In fact, all over the world, healthcare systems are beginning to understand that this is a huge problem. It hugely affects people's quality of life, and of course, their longevity. And there is something that we can do. We're realizing there's more that we can do. So, of course, when you look at Ontario comparing to other areas, other developed countries in the world, we haven't been doing that great as far as preventing amputations. You know, if you look at the bar there, you can see us compared to many of the other countries that you may recognize. And, you know, we're really not down at the bottom where we would like to be with our amputation rates. And so this is recognized as something that could be done. And I was actually originally approached by Core Health, by Lynn and her team, to say that they were looking at ways for Ontario to develop a framework, some way that we would consistently address these amputations and try and prevent them sort of downstream. And if you look at our province there, so this is an Ontario initiative that we started to develop, and I was privileged to be the chair of the clinical framework development team. We spent many months as a group sort of hashing out the details of this particular framework. But you can see that, you know, if you happen to be near a nice urban center, like, you know, you're downtown Toronto and you're probably, you know, pretty affluent, and you've got 5 hospitals within sort of your spitting distance, your amputation rate is going to be a lot lower in the green than it would be, say, if you're way up north where, you know, the amputation rates are way worse, partly because of the Indigenous populations and their own struggles, and partly because of the distance, of course, not having the same access to healthcare. And of course, if you sort of span out from the GTA, you see that distance to these centers makes a big difference. So how can we help people have access to the kind of care that they need throughout their health journey, so that they don't actually end up to the point now of having such a serious condition in their lower extremity that they actually need an amputation? And I'm going to ask you to forward to the next slide, please. So, I mean, when you look at the issue here, you've got, you know, 1.5 million people have diabetes. Diabetes is a pandemic, right? It's the other pandemic that nobody talks about. And then, of course, those people will get foot complications because they don't have the sensation. They have problems with their vasculature. They don't have the sensation. They're going to injure their foot without even knowing it. And, you know, oftentimes it's long-term diabetes that then causes the development of the vascular disease that eventually causes the hole in the foot, partly because of the neuropathy and partly because of the poor vascular flow in many patients. And then, you know, you're looking at 15 to 25% of them have these problems in their lifetime. So, when you think about it, we're an aging population, right? So 15 to 20% of people over 70 years have peripheral vascular disease. Well, look at the amount of our population now who are over 70, right? We're an aging population, so we're seeing more and more and more of this. We're getting better at keeping people alive with our chronic disease management, but by the same token, we're going to have more people with peripheral vascular disease. And so, you know, if you have diabetes and peripheral vascular disease, your risk of amputation goes up incredibly. We're looking at 2,000 amputations every year, one major amputation every 5 hours. And when you think about that, you know, if you can have a toe amputation rather than a major amputation, and then you can manage from there on in, with good care and good follow-up care, you may still be ambulatory. You may be able to still stay at your home. You may not require long-term care, which we also know is overburdened. And many people, once they have an amputation, especially later in life, they're not really candidates for prosthetics as we see every day. So in order to do this, we need to be able to early identify these issues, right? So we cannot do this alone. We need this as a prevention system, like from the get-go. It doesn't all have to be NSWOCs. You know, if you can train PSWs and family members and other people to at least look at people's feet and report if there's a problem, then you're going to help people out a lot. And then, you know, you need to make it available to all of the people as far as being culturally safe and so on. So our messaging, we need help from all of the community to make sure that the people that need that information can get the information in a way that's accessible to them. And of course, we know that we can prevent up to 85% of amputations and reduce costs and admissions. As you know, many patients with diabetes, one of the most common reasons for hospital admissions and lengthy admissions is actually soft tissue infection. So if we can save this huge number of lower limb issues and amputations, then, you know, not only do we reduce costs, of course, but we improve quality of life. Next slide, please. So Ontario has one of the highest lower limb amputation rates compared to similarly publicly funded jurisdictions in the world, as we showed with the initial slides. The Indigenous population, it's up to 7 times, as Lynn mentioned at the beginning. And so Ontario Health partnered with this advisory committee to develop this lower limb preservation integrated care program, so that it's coordinated with all of the people that need to be involved. It's integrated into care teams and it's patient-centered. And we want to improve the outcomes for patients at the highest risk, of course, for lower limb amputations, especially Indigenous and marginalized patients, of course. We want to reduce avoidable non-traumatic major lower limb amputations and improve the equitable care across the continuum. Next slide, please. So the framework came with a package, and you can find this, I think the Core Health website is still up. Going to be provided for you, putting in the pieces that we need in stage, in the wound stage, and in the remission, they can keep their limbs. It's a system level pathway that highlights the key activities that are required in order to prevent and manage lower extremity wounds. Underpinning this whole idea is the idea that every lower extremity wound is a vascular wound, but many of the people out there looking after lower extremity wounds do not understand this. They may look at a heel, for example, and say, oh, that's a pressure injury. With an aging population, and certainly with people with diabetes and cardiovascular other issues, they've had a cabbage, or they've had stroke, or those kinds of things. You have to rule that out, as we all know, is the first thing we're going to do. So underpin every lower extremity wound is, and then there are minimum care requirements to standardize limb preservation, no matter where you are living. And there are key considerations to the model of care, guide development, and delivery of the integrated regional lower limb preservation services. And there are now several pilot areas that are actively implementing this framework within their different areas. So it's going to provide guidance, and I'm going to ask for the next slide, please. And you may recognize this sort of traffic light image from Wounds Canada, the diabetic foot, right? And we did this on purpose in collaboration with Wounds Canada to make this very intuitive for people to follow. So you can see that the green little list there is about prevention. The red is about managing the wound, and the amber is the remission, because we know that once that wound is closed, that's not the end of the story. This is a time when they're much more likely to break down again if they don't have the follow-up in place. So these pathways include regular preventative screening for people at risk, early identification of issues so that we can get on top of that quickly, and it's a small problem, not a big problem, timely assessments, best practice treatment, links into the best practice documents, ongoing surveillance. It's not the closed wound and on you go. There must be some way to follow up. It doesn't necessarily need to be, in the medical system, but somebody needs to be following up with that person. Culturally appropriate patient self-management education, something that's accessible, as we said earlier. Cardiovascular risk factor management, of course, to stem the development of the disease that leads to the cause of the tissue loss in the first place, and wound prevention strategies. Next slide, please. And then, of course, there are minimum care requirements. So, we know that people should be getting basic care as NSWOCs. We fully understand that. And everybody deserves a prevention strategy. So we're looking at lower limb wound prevention strategies. We're looking at active wound management for limb preservation, and then ongoing surveillance. And this document describes how to assess, how often things should be assessed, and the components of interprofessional care, which is critical so that people get all of the services they receive. Of course, none of us can do this alone. We need our interprofessional team, our chiropodists, our occupational therapists, our dietitians, our physicians, and so on. Next slide, please. So key considerations for such a model of care, it's meant to offer practical guidance. And so I hope you find it useful, and I hope you find it useful for the people that you are following, and their families, and their support services. We want to reduce avoidable lower limb complications and amputation. We got a little music going on in the background. I apologize if you can hear that. And keeping people at risk for lower limb complications and amputation, keeping them well. And we, of course, we want to reduce acute care utilization, especially now when we're in constant emergency room challenges. Next slide, please. And this is a change package that accompanies this. And that provides some actionable ideas and tools. I invite you to look at this, dig it out, and you can adapt this based on your regional needs. And I think I'm about wrapped up there. I'm just going to see the next slide. Yeah, the change package focus. Again, the idea of integrating care teams, equipping patients and their families, and measuring outcomes to make sure you're actually getting somewhere. Of course, as NSWOCs, we know this. Next slide, please. There we go. And with that, I would just like to say that it has been my pleasure to have worked with Core Health, now Ontario Health, to help guide the team that put this together. This was not my work. This was a big group effort. And Lynn and Mike Setterfield really helped put this all together. There's been an awful lot of work going into this. And Wounds Canada supported it as well. And, you know, we've had NSWOC expertise and vascular surgeon expertise and so many people involved in this. And it is our hope that this will be used by yourselves and the people that you are the amputation. Thank you.
Oh, thanks, Chris. We got a little bit of 80s vibe with some max headroom, a little bit here and there, but you did a great job with introducing the lower limb preservation framework, and appreciate all the hard work and leadership you did in putting this together with Lynn and the rest of our team at Ontario Health. So thanks everyone for having me here today to really talk about the implementation of this work. So it's one thing to have our guidelines and our frameworks on paper and seeing that red, yellow, green, but it's a whole nother initiative to be able to put this into practice. And we know that that knowledge translation component of the work and change management component of the work is really the key for patients and providers as yourselves to having a better integrated system so that we can be more effective and save limbs. So at Ontario Health, and again, led by Core Health and part of what we call the value-based care team, which is a part of the population health management side of Ontario Health, was given the green light to use the framework to build some integrated clinical pathways. And this really stems from, in Ontario, there was the development of Ontario Health teams. So there really was a healthcare reform in the community, which is still ongoing and got a little bit interrupted by a pandemic, but really starting to get the ball rolling on the OHT approach to care in Ontario. And the reason why this shift in the way we approach healthcare was developed is because we're moving away from that siloed kind of fee-for-service sector type healthcare delivery and towards more of a population health management model of care. And what that means is that we actually utilize the data that we have through Ontario Health and different administrative databases, and we pull some of those healthcare outcomes and evaluate where in these OHT catchment areas, so we call that an attributed population, where within those OHTs are there certain needs for the various communities. So in terms of lower limb preservation, looking at where is there a high patient population of diabetes, perhaps unattached patients, even knowing what we know about the social determinants of health and how important that is in terms of health outcomes, how is that built into these models of care as well? So you may be reading a lot more about mobile buses and outreach and really trying to support and underhoused patients and being more targeted in our approach so that we can move some of this care and healthcare upstream. So that is that green section. We want more people in that green section of the framework and allow people to be really engaged in keeping themselves healthy rather than waiting for the problems to occur, trying to move that upstream. And it was an announcement not too long ago by the Ministry of Health here in Ontario that said, okay, let's do this. We have these OHTs, but we've been working on them since 2019. Let's show how we can make improved clinical outcomes for patients through the OHTs by implementing integrated clinical pathways. So you can see the 4 that they've approved there. Lower limb preservation. Heart failure was the first to go, and lower limb was a close second to follow. And now you might be hearing in some of your various communities around further congestive heart failure teams and COPD teams are on their way as well. So this is a bit of a busy slide, but just a visual about what I was explaining in terms of population health management and the approach to care, and that we have that 5% of patients utilize 80% of the healthcare dollars. And that's typically because we have that reactive approach to healthcare right now, where people kind of percolate in the system. I know all of you as NSWOCs so closely with NSWOCs as part of my interdisciplinary team, interprofessional team. And I know we've all been in patients' homes and knowing things are going downhill and they don't have a family physician, and we call the care coordinator, but like, who else do we call? What do? We can watch it happen in front of our eyes and we don't know who to contact. Or patients aren't coming to the clinic to receive their sharp debridements on a regular basis that we know they need because they can't get there. Or we're providing them with an offloading device and they're taking the bus and have to walk a kilometer to the clinic. So we want to be able to utilize the OHTs and flip this on its head and look at social determinants of health, move some of that education and prevention and treatment upstream so that we can reduce those healthcare costs and really get the care in the right place at the right time, closer to the patient's homes where they want to be. So out of these initiatives came the lower limb preservation integrated care program. So the objective with that was that we would identify what we call demonstration programs. And the demonstration programs are paired with the vascular centers for this initiative. So because we know from the framework that everyone who presents as a high or urgent risk, even our moderate risk patients, they need to have a vascular assessment. Like Chris said, we need to assume that everyone with a wound in their leg or foot has a vascular wound and they require that interprofessional care. And so in Core Health partnered with OH at the time. Now they've been enveloped and are part of Ontario Health. And we began to identify change initiatives. So we had what was called an action plan, and we asked teams, where are your gaps in care? And we really just used a quality improvement model to help guide some of the change initiatives, gaps in care, and moving from this current state of more siloed care into a future state of upstream care. And within that, we have a community of practice that helps to support these demonstration programs. We've built in patient-reported outcome measures for the teams, and Ontario Health has even done some really great work in terms of integrating some of this data so that it can be collected and evaluated across the province. So these programs are really trailblazing for all of us, how we can scale and spread across the province. And again, like Chris was saying, there's a lot of excitement around this work, and it's been so I can't even do the math right now, but for as long as I've been involved in wound care, I think this is the most I've seen people really engaged into making this happen and looking at diabetic foot ulcers and saving those limbs. So it's been pretty exciting to be part of the work. So these demonstration programs, it's all across the various health organizations and that you see listed there, but it's also bringing into the community services as well. So we not only look at some of the healthcare interventions, but we, like I said, the social determinants of health as well is very important in this work. I mean, I know we've learned a lot as NSWOCs about nutrition and wound healing, but when you go to the fridge and it's empty, it's hard to provide that education. So we need, and clean socks. We've all seen patients and put them back in their flip-flops that are falling apart and wish we could help support them just to get a clean pair of socks and shoes. So this work has allowed that to happen. And it's been really rewarding in terms of patient outcomes, but it's also been really rewarding for the providers to have an opportunity to provide patients with what they know they need outside of perhaps a prescription. So it's that part's been really great too. And involving the patients to co-design and be part of the process of building the integrated clinical pathways has been great. And we get to work with these teams on a regular basis and meet some of the patients that are providing that input and co-design. And it's really exciting stuff to see it go from the page into real life. So these are our 12 lower limb preservation demonstration programs, and you can see the regions that they're in and their OHTs and also the affiliated vascular centers that are involved. We've got lots of engagements and supports for these teams. As there's been the more ICPs, we call them Integrated Clinical Pathways, ICPs, rolled out, more and more supports have come out of the woodwork too. So there's lots of opportunity to learn not only population health management, but around the clinical expertise and beyond. So we have regular check-ins with the teams. We do, like I said, a quality improvement approach. So we do the PDSA, the plan, do, study, act approach. So we do have lots of measurement and evaluation at a local level, also at a provincial level, and of course, building in all that qualitative data too. So important to hear the patient stories, the provider stories, more than just numbers in an Excel spreadsheet. We want to make sure that some of this is more the qualitative data that is showing us how much it makes an impact. And then we also have a community of practice. So Chris touched on this a bit too, where it is open to everyone. So please join today if you have special interest in lower limb preservation. It's from what we call the shared space. It's a RISE platform. So RISE is out of McMaster, and they're really leading the charge for OHTs and some of that population health management science. This is the shared space and the community of practice. So when you go in there, you can talk to your various team members, ask questions, and then we also have all the resources that are needed on there. We've had some really great webinars. We've had experts across the province and join us and beyond, and learned about new research and educational opportunities. Our next one coming up in February 8th, we're going to be learning about lower limb preservation and mental health. So we all know that part of the OHT role also is looking at chronic disease models. So we know that people with diabetes and diabetic foot ulcers, it's likely not the only thing that they're dealing with. So looking at all the aspects of care. And this is a different visual of what the framework showed us. So really trying to show that upstream care, looking at early identification. So one of the pieces that a lot of our teams are embedding in the work is risk assessment. So looking at in low risk assessment tool, determining the patient's level of risk and sending them along the pathway that's most appropriate for that level of risk. Of course, we have to build in our specialized wound management teams. We all know that there is a lot of expertise in terms of working with patients with high risk diabetic foot ulcers and vascular wounds, and they need to be managed as such because they can turn on us very quickly and end up with an amputation. And then when we do need to escalate care, we have our acute care centers. But the important part is that we're all speaking to each other. We know where to go, who to talk to when we need to escalate care. And we also decant appropriately to make room for the next alarm bell that we need to address in terms of our patients. So being able to trust to put those patients back into the community and have that more flow rather than having to be on the wait list for weeks when we know it's an urgent situation that we need to get patients assessed. On the right there, we're just looking at some of the key outcomes that we're tracking as a province. And what's not, you don't see in there is the qualitative aspect of the work that we talked about. And that's what this slide shows. So these are some comments and enablers and resources that have been developed by the teams across the province. These are early days. I would say we could even add to this now, but anecdotally, we've had a lot of really positive outcomes, and we're just about to get some more local metrics to take a look at. But we know it takes a bit of time to move the needle. That's something that we learned. I'm sure there's colleagues on here from Alberta, and we will learn from the research out there between Edmonton and Calgary, looking at some of the different pathways that it can take upwards of years to really see the changes. So we look locally and we look at some of these qualitative outcomes to keep us moving in the right direction and keep ourselves and the ministry engaged as we scale and spread across the province. So with that, I will pass it over to Lynn to talk about some of the focused Indigenous health.
So good evening again. You've now heard from the wound experts, and I am excited to share with you some of the Indigenous health components of our project, as Lyndsay said. And so the Ontario framework for lower limb preservation that Chris spoke to start the presentation tonight highlights that it's important to consider Indigenous approaches to care and culturally safe care delivery. And really, we're all continuing to learn and understand what that means in action. You can flip to the next slide, Lyndsay. Thank you. So as a first step, it's important to understand the Indigenous population and community you are engaging, to understand their existing system of healthcare, including the programs, leaders, and funding. And that too is often different across Indigenous communities and can be quite challenging to figure out. I think most of us would agree. So of course, we now also understand that what we learned in school in Canadian history class wasn't the true story. And as such, we are all encouraged to take Indigenous cultural safety training to understand the history and experiences and stories of Indigenous peoples in Canada, and really to work to better understand the key healthcare challenges Indigenous peoples continue to face today. And additionally, in support of Indigenous health in Indigenous hands, it's so important that Indigenous peoples are in control of their own health decisions, programs, and resources, and that we work to build collaborative relationships based on trust and respect. Next slide, Lyndsay. So because of high amputation rates in Indigenous populations in Ontario, we decided that our provincial lower limb preservation team would take an Indigenous health focus. And really, we aim to support and guide the demonstration programs around the province with Indigenous approaches to care and culturally safe care delivery. There are Indigenous leads, both at Ontario Health, provincial, and also in the Ontario Health regions. And so we have the privilege of working very closely with them. They actually know the communities, the Indigenous partners. And so together, We help demonstration programs to identify and build relationships with Indigenous peoples, communities, organizations in each of the regions, and really guide them in co-designing lower limb preservation change with those Indigenous peoples. And one more objective, as Lyndsay referred to, the community of practice. We coordinate the sharing of Indigenous resources, including patient education, materials, cultural safety awareness training, to support providers in providing holistic, culturally safe care. And I'll have a slide on that in a minute, just to show you a little sneak peek into the Indigenous health component of the community of practice. So the next slide, we are really excited to share examples of some of the Indigenous-focused lower limb preservation change initiatives that the demonstration programs are implementing. And I know there are people on this call who could speak to these, to speak to this work and these change initiatives better than I can, because they're doing the work in these regions, but I will do my best. So the demonstration program, as an example, in Barrie, has implemented a new foot care outreach program supported by a clinical navigator. And Indigenous patients are being seen for foot care in the Mamaway Primary Care Team mobile clinic and at the Barrie Native Friendship Center. So that's one Indigenous-focused example. The second, the demonstration program in the Northeast of Ontario, made up of the MClSc Ontario Health Team, Indigenous-led, and Health Sciences North in Sudbury. They are implementing a diabetic foot ulcer and vascular wound prevention referral pathways, beginning with the in-low foot screen and lower limb vascular assessment, which they have embedded in the electronic medical record system in all of the communities in the primary care centers in each of the communities. So these pathways are for residents of the 11 Indigenous communities, as well as the urban Indigenous population in Sault Ste. Marie. And really what I was most excited to learn about is that all patients within these pathways are offered the opportunity to see a traditional medicine practitioner to support their care. So a real Indigenous focus right at the start of the new pathways. And this team has everything they do as an Indigenous focus and is culturally safe, but they've taken steps to offer cultural competency training, lots of different activities on a regular basis to any of the healthcare providers across the region that are becoming involved in the program. And they also, for example, offer kits of sacred traditional medicines for patients as part of that pathway and that traditional medicine practitioner opportunity. And lastly, on this slide, the Northwest demonstration program is also engaging Indigenous communities and really educating frontline healthcare providers within the Indigenous communities so that they build knowledge and capacity within the community for foot screening, lower limb assessment, and the knowledge of when to escalate care through the Northwest Ontario Regional Wound Care Central Intake. They're also providing, with funding through this program, shoes for people living in remote Indigenous communities who aren't able to access proper footwear. And lastly, they're using digital technologies such as the TeleView glasses to connect patients in remote communities virtually with the wound specialist and care in Thunder Bay. So we're so excited to see the success of these demonstration programs and lower limb preservation change initiatives in the coming months. The next slide is that little sneak peek into the Indigenous Health folder on the lower limb preservation community of practice. And it's on the online shared space, as Lyndsay mentioned. I did pop the link to the community of practice in the chat, and you'll just have to hit the, what I think it is, the sign up button in the top right corner to register to join. But as you can see, this is specifically the Indigenous Health folder that's on the community of practice, and it includes a number of really excellent foundational documents from a number of different organizations. The one that I refer to often actually is the map of Indigenous communities across Ontario. It has guidelines and toolkits for relationship building with Indigenous communities. And we also shared a list of cultural awareness, competency, and safety training courses for teams to consider accessing. So the next slide, really, there's also a lot of work that we're doing at a provincial level, or that our team is involved in. So Ontario Health has a provincial Indigenous Leadership Network, PILN, we call it. And so we participate on PILN. It really includes anybody at Ontario Health or in the Ontario Health regions that are doing anything Indigenous related. And so it's our opportunity to gather, to share, to learn from each other, to align our work, and for us to really seek support and guidance on our lower limb preservation Indigenous health work. We also have, our Ontario Health has an Indigenous health equity and coordination team. So they really do oversee all of the provincial work, and they chair that PILN network that I just mentioned. They're developing a First Nations, Inuit, Métis, and Urban Indigenous health framework that supports all of the teams and project teams within Ontario Health with sort of a process to engage Indigenous partners, a relationship build with Indigenous partners, and building on that health framework. They're in the process of building a health plan for Indigenous peoples in the province of Ontario. And then lastly there, we sometimes we engage with regional or provincial Indigenous organizations, such as the Métis Nation of Ontario, as an example. I sit at their Chronic Disease Circle of Knowledge. The Indigenous Diabetes Health Circle is another example. And really we seek their help to support the demonstration programs. So we connect them with the demonstration programs, and they help with partnering and programs and resources. So lastly, we also thought you might be interested to know about a new process at Ontario Health related to Indigenous data. So Indigenous data governance, as you may know, is the recognition that First Nations, Inuit, Métis, and urban Indigenous peoples have sovereignty over the collection, ownership, and application of their own data. So this new process at Ontario Health, called Indigenous Data Governance Matters, or IDGM, provides all of the project teams at Ontario Health with a standardized approach to appropriate Indigenous data use. And really, it will ensure that projects do recognize and support the sovereignty of Indigenous data. And so our provincial lower limb preservation team has submitted an intake form. That intake form goes to Indigenous data, or sorry, what are they? Nation distinct data groups within the province, and they review the intake forms and provide feedback so that we can ensure that the way we are using and collecting and sharing Indigenous data is proper and respectful. So that is, we've come to the end of our formal presentation. Thank you so much for listening, and we would be happy to answer your questions. Kathy's popping back on to.
Yeah, thank you. That was really informative. Really staggering numbers. The numbers that really resonated at the beginning of the presentation. You said that in Ontario, amputations are 7 times higher than the provincial average in Indigenous people. That's that's a staggering number, and $51 million is spent in amputation related costs annually. And I'm sitting there thinking, you know, what action is being taken? I mean, I think you're taking action there, but at the government level, what action is being taken? Anybody want to answer that? Maybe Lyndsay?
But you know what? I got distracted. I was reading the chat, all the great chats. So do you mind repeating the question, Kathy?
Yeah, like 51 million in amputation related costs annually. And I'm like, what action is being taken at the government level, particularly the provincial government level?
Yeah, well, I think that's what we're trying to do with these demonstration programs.
Mhm.
So really trying to keep everyone educated about bringing services upstream, because we know 85% of these amputations that are happening, Chris said like 2,000, one every 5 hours, are preventable. And it's simply through asking people to remove their socks and look at their feet. It's not some kind of diagnostic test that you have to do. Anyone can do it, as Chris alluded to as well. As long as we can ask people to remove your socks, take a look at your feet, teach some self-management, along with what we're doing in terms of teaching about other ways of managing their diabetes through medications and nutrition and diet. This needs to be built in as part of that work. So we are collaborating with various teams across Ontario Health. Like, we do have primary care teams. We have, of course, our core health team focusing on the vascular and bringing in the acute care aspects of it. But we also have primary care teams. We have chronic disease management teams, preventative teams. So ensuring even across the organization that they're aware of the work, and everyone is really clamoring to help support these demonstration programs, because they know that it is such a high impact change, with some pretty it doesn't have to be complex interventions. I mean, even like we said, looking at some shoes, perhaps custom orthotics. This is where we can get the information from the teams. I think a lot of times us as clinicians, we've had some of these like, oh, it's really frustrating when I know what they need, but I can't get it to them because there's these financial barriers. So really working with the Ministry for Financial Reform to allow for some of these social determinants to be funded through the work of the OHTs, so that we can have an opportunity to prevent, rather than funding, the hospital stay and the more acute side of the disease.
Okay. Yeah, well, it's quite staggering, and there's several questions that have come in here. One primary goal is to offload wounded feet when discharging people from acute care. How can we advocate for the cost of offloading shoes so that we can optimize wound healing? So any ideas around advocating for the cost of offloading shoes?
So in Ontario, we do have funding for Tier 1 devices. Tier 1 devices are total contact cast, removable cast walkers. We are currently working with the ministry to expand that funding envelope to allow for some of the Tier 2 devices, which is your custom orthotics and even Darko shoes, and trying to really advocate for patients, because you're right, a lot of patients have those financial barriers, and offloading is like the key component to wound healing. And in some cases, in that green bucket, in prevention, we can almost see it coming. So how can we move some of this care upstream, and trying to advocate for patients? And I think we're closer than we've ever been now that we do have these OHTs, knowing that it's population health management, and a key component to that is looking beyond just that acute care piece of patient care.
And I would actually add, Lyndsay, that adding the AMBER, the remission piece in the framework,
absolutely
is key, because I think it's not common for government officials to understand that wound healing doesn't end when the wound is closed. Now we've got a situation where often they recur out in the field. We all know this, that that the person comes in and they heal, and then 6 months later they're back with something else because they didn't have the shoe, etc. But putting that AMBER remission piece in the framework really highlights the fact that, okay, the wound's closed, but they still need follow-up, and they still need support, such as the the offloading footwear, etc.
Mhm.
Okay. The next one, and Chris, you may want to answer this to start, is curious to know what or how your HCC teams are involved in the lower limb preservation programs.
Yeah, so the home and the community care teams have to be integrated. So this is a community of practice, not just sort of a meeting point, a virtual meeting point for people that are interested in lower limb preservation, but it's actually a functional community of practice whereby we are trying to take down the walls between the different agencies. So whether it's home and community care, or whether it's our local Indigenous group, whether it's the mission and so on, we have been working to bring down those walls, and we're actually, our teams are sort of pulling those people together. So in Ottawa, for example, all of those people are represented in our community of practice. So we're trying to serve patients together along the continuum of care. Certainly in our clinic, we do virtual visits, and we include the home care nurses in the visits, so that we're coming up together with a collaborative care plan, not sort of a dictated care plan, because we know, I mean, clearly it's the community nurse that's often doing the lion's share of the work out there. So we absolutely need their input, and to know when things are changing and so on. We need them as co-drivers of the care plan. So yes, to pull in everybody in these community of practices, with everybody having an equal voice, and then also having the more rapid referral systems. So often the home and community care nurse will see somebody and they know they need to see vascular urgently, and right now they've got to go, you know, to find a family physician or somebody that's willing to refer them and so on. And we're actively working at pulling down these barriers. And as the different centers come up with these ideas, and then we collaborate between the different centers, the idea is that sooner or later we'll share our ideas, and you know, everybody will have this more rapid access to care and integrated care.
Yeah,
And
and I'll just add to that, Kathy, that I think my biggest, you know, one of my fears too is that a lot of times these projects happen with some of the administration and leadership teams, but the messaging to trickle down through all those avenues to the front line, to the providers like yourselves on this call who actually do the work with the patients. I'm always worried about those communication channels. So if you're out there and you say, hey, my OHT is on that list and my vascular center is on that list, I really urge you to talk to your agency and reach out to your OHT and say, I know they're part of the lower limb preservation demonstration program. I work for this agency. I'm in home and community care. I'm in community support services. And how do we fit into the pathway? Because I really want to help. And so I think there is this top-down approach, but, you know, I encourage you to use bottom up as well, because sometimes the message just doesn't get to the most important people in the pathway, which is yourselves on this call. So,
okay. Another one, I know that in the Southeast Lynn, we're required to complete a lower limb assessment with ABPIs with any wounds below the knee. However, with the shortage of NSWOCs and doctors in my area, this is difficult, especially since I am a SWAN. Do you have any suggestions on making these referrals easier?
yes. And I think, well, I should let Dr. Murphy take this one probably, but just in turn, I know not only for diabetic foot ulcers, but also when we're talking about venous leg ulcers, and that nasty ABPI is in a lot of those policies. And as we learn from the research and some of the science, we also know that delaying treatment and delaying best practices can lead to more chronic wounds. And so, you know, okay, there's a risk of doing, but there's a risk of neglect. And I would argue sometimes that's the higher risk. So I think we need to build in ABPIs are a part of our toolkit. It's a piece of the puzzle, but it's not the whole story. And there's a lot that your clinical assessment, your clinical judgment and knowledge can do to help advocate for that patient and as part of the interprofessional team, using something like the handheld Doppler and listening to waveforms to help give you that confidence of whether a patient needs further assessment prior to doing your intervention. But again, this is why your interprofessional team is so important, because it's a piece of the puzzle, but we tend to, as wound care clinicians, hang our hat on these ABPIs, and it can be inaccurate for a variety of reasons. And I think it just delays the best practice interventions in many cases as well.
Yeah, I would say that, as we've said, all lower extremity wounds are vascular until proven otherwise, but there are multiple ways to sort of assess that, right? So again, as your assessment skills improve, you know, if you've got bounding pedal pulses, you really don't need to follow up with an APBI in most circumstances. If you have a patient that has been seen by vascular surgery last week and they're telling you, you know, their perfusion's okay, that should be enough, because they've read the CT scans and they've looked at all of the different possible occlusions and they've checked the stents and they've done all that. The APBI is not going to be accurate in those kind of patients. It's going to give you some kind of information, but it's not going to be as accurate as a vascular evaluation. So it's one thing, but it shouldn't be a yes or no. And again, your clinical knowledge. I mean, if you see enough of these arterial limbs, you know who's in trouble. You get to know that very quickly. The ones that are borderline, you may have a little bit more time to figure that out. And then the other thing is your interprofessional team, right? So if you have chiropody, if you have other people in your team that can be doing these APBIs, if that's the requirement, then, you know, reach out to your interprofessional team. Maybe your OTs are interested, like, you know, see who else might be interested out there to do this with you.
Mm-hmm. And we have time for just one more question. Is total contact casting the most common tier 1 offloading intervention for the Indigenous population?
It's the gold standard. I wouldn't say it's the most common. We would love it to be the most common, but we're striving for it to be the most common. But there's many reasons why it's not. There's some great opportunities to increase the use of total contact casting, because there's some great easy kits. All you really need, you know, you need a cast off or removal, but just really a bucket of warm water to apply some of these kits. So I think a lot of it is around education and understanding of why it is so important. So, you know, I've heard some micropathy colleagues say it's not an option when you break your tib fib, right? You got to put on a cast. So why, when you're at the same risk of having, you know, lifelong vascular issues and even amputation, why is it not mandatory? So I think it's just that patient knowledge to get them engaged. And there's a lot of activities of daily living that are limited through total contact casting. But again, it's you know, I know patients who say, I don't want to wear it, I don't want to do that because I have to drive. And it just, yeah, but it's really hard to drive with a prosthesis as well, which might be the outcome if we don't manage this appropriately. And so understanding the barriers, financial barriers, and there's a lot of things that patients have to deal with. That's why the upstream again is so important, because let's get them before that wound develops, and then it doesn't have to be that tough decision of I have to be out of work for 6 weeks versus saving my leg. So
yeah. And there's a last statement here, and I think, Lynn, you may want to comment on this. Unfortunately, for many of the First Nations clients I see in my clinical practice, amputation is often viewed as an acceptable outcome. We need to focus on this.
Yeah, it's an interesting comment. And I would say that it's sometimes actually viewed as an acceptable outcome for any patient, not just an Indigenous patient. In fact, our patient advisor who helped us develop the framework, he selected a lower limb amputation and higher than was initially recommended because he felt that was the best outcome. And so there is a little paragraph in the framework that talks about amputation, because it is sometimes an outcome, but it's also sometimes an outcome that is chosen by the patient. So I just, I would certainly want patients to be informed of all of their options. And so in this case, if the patient is well informed and still is making that decision, then it's their decision to make.
Okay, well, we're already at 8 minutes after 8. I wanted to take the opportunity to thank Lynn and Lyndsay and Chris for their time this evening and sharing their experience in their lower limb preservation integrated care program. And hopefully we'll start to see the needle move and start to see the amputations coming down moving forward. Thanks for all the great work that you're doing. And if anybody has a question that wasn't answered, you can email us at office@NSWOC, NSWOC.ca, and we will connect you with the presenters and make sure you have your questions answered. And thanks to everybody for taking the time to attend, and we look forward to see you at our next webinar. Thank you so much.